So, good morning, everybody. I think this is a very important session which we are all going to attend in terms of looking at a very important type of diabetes, type 1, and the need for insulin. So, type 2 diabetes and the oral hypoglycemic agents, they get a lot of attention. So, it is the primary topic which is usually gets covered in all the discussions and deliberations. But we should not forget the fact that type 1 diabetes, a visit to understand it better is very, very important. So I request the audience present here to pay the utmost attention to this topic. So we request Dr. Arun Raghavan to present on tailoring diabetes therapy, the role of once daily insulins. Welcome.
Yes, like you highlighted, this is also a very important session topic, as we know that after failure of OADs, we need to initiate insulin on time so that we don't create large window periods of hyperglycemia, potentially culminating into complications, right? So again, before I move on to my slide deck, thank you very much, the organizing committee of TRAC, for having me here, and also my respect in regards to all the teachers, professors in front of me. So what I'm going to be highlighting about is once daily insulins, and this is an industry-sponsored session, so I'm going to talk about Novo Nordisk products. However, these are the two molecules that I very often use in my clinical practice, right? So I'm going to start off with a case scenario so that we understand how we can initiate insulin. So here we have a person who's about 50 years of age, diabetic for over 10 years, having a fasting blood sugar of 188, postprandial of 218. HbA1c is almost about 9%, right? Something that we routinely see in our clinical practice, right? So patient is already on multiple agents, including liraglutide, empagliflozin, and metformin. How do we approach this patient, right? Technically, he's on 9 non-hypoproducing drugs, right? If you look at it, patient is not on a sulfonylurea. One is you can, of course, consider starting sulfonylurea as well, but however, we do not know whether we may achieve the HbA1c reduction of 2%. And what about insulin in such a patient, right? And if at all we consider insulin, what would be the ideal insulin to start off, right? Now, this patient, perhaps since he's already on an injection, would be open to take another shot, right? It's not something that patient is having a needle stigma or fear of injection, so on. But this patient has fear of hypoglycemia, right? So despite multiple OADs, when we keep intensifying, adding a third or fourth OAD, we may not get the desired HbA1c reduction, right? After 3 OADs, adding a fourth OAD, you may maximum get about 0.4 to 0.5%, right? So that's the challenge. That is why we are considering insulin for such patients. So the guidelines have been quite explicit. Of course, GLP-1 receptor agonists are the cornerstone right now, considering their extra glycemic benefits. But obviously, it is not an agent where, as a blanket rule, we can give every patient, right? So after OAD failure, the main agent that we rely on is a basal insulin, right? So basal insulin is the go-to drug after OAD failure. So which basal insulin and why basal insulin do we consider? So the challenges of the first generation basal insulin, such as NPH and other insulins, of course, glargine U100 became the benchmark, right, of basal insulins. Why it became the benchmark? Because we were able to initiate at, say, 0.2 to 0.3 units per kg once daily, and we were able to largely overcome hypoglycemia when we moved on from NPH, right? So glargine U100 was a game changer, isn't it? But now the second generation basal insulin analogs, such as glargine U300 and degludec. Now the difference between the second generation basal insulin analogs is almost the difference between the NPH and U100. That's the difference of hypoglycemia between the U100 or U300 or U100 and degludec, right? Now what we require from a good basal insulin is not potency, power, where you get rapid blood sugar reduction. What we expect from a good basal insulin analog is a very flat profile, peakless profile. That is what we expect from a good basal insulin analog. So our expectations from a short-acting insulin analog is completely different from a basal insulin analog. So the first generation analogs, as I mentioned, are not truly once daily. They also have peaks, right? So there is the risk of hyperglycemia. So that's the advantage of insulin deglutec. So how do we initiate insulin deglutec? Now, earlier, we used to initiate at 0.2, 0.3 units per kg, but then the easier way to approach is start at 10 units, and then after 5 to 7 days, look at patients' fasting plasma glucose levels, and then up titrate accordingly. However, obviously, if patient's HbA1c is very high, you can even consider a higher amount of basal insulin. But the general thumb rule to initiate would be about roughly 10 units once daily. Now, moving on to the sensitive topic about which of the newer generation insulin analogs would you go to, right? Now, deglutec, U300, both are the newer generation insulin analogs. And when we start insulin analogs, patients who are probably first time experiencing insulin, one of the key things to keep in mind is, of course, we don't want patients to land up in hypoglycemia, right? Even once if the patient lands in hypoglycemia, they're going to have fear of continuing the insulin, right? So that's something that we are all cognizant of. So even if the HbA1c is marginally low, say about 8, 8.2, it is better to prefer the newer generation insulin analogs because the threshold of HbA1c reduction is actually narrower, right? So that is where the hypoglycemia risk is also high. So these are the potential patients who would actually technically benefit from the newer generation insulin analogs, right? Because the incidence of hypoglycemia, as I mentioned, is much lower. And obviously, I think another key point that I would also highlight is, patients, we need to initiate insulin recognizing OAD failure. Now, majority of our patients have to be primed much earlier that you may require insulin 6 months, 1 year later, right? I think that is very, very important factor to deal with because one fine day, you tell the patients abruptly, now all your OADs has failed, I'm going to start you on insulin. It's not going to work, right? Because they are on continuous follow-up with us, we know that we are intensifying OADs, and at one point in time, we know that this is the milestone where this patient may perhaps require insulin, right? So that, I think, has to be, kind of primed much earlier and, break all the myths surrounding insulin so that patients are quite sensitive and receive it well at the juncture when we actually initiate insulin. Now, as I mentioned, there was the BRIGHT study earlier, there were the CLAMP studies having some conflicting data between both deglutec and U300, right? But we did have the CONCLUDE study. It looked at 1,500 patients between deglutec as well as U300. We also have the CONFIRM study, which is a real-world study, demonstrating insulin deglutec has significantly lower risk of hyperglycemia versus U300 from real-world evidence, right? So we have 2 studies now to actually demonstrate that insulin deglutec actually has a lower risk of hypoglycemia compared to insulin glargine. I think the slide deck is not moving. Yeah. So insulin deglutec has shown a significantly lower risk of hypoglycemia. So the proportion of patients experiencing more than one episode of hypoglycemia was significantly lower with deglutec versus insulin glargine U300. So I think this has probably, assured 2 studies have assured that U300 and deglutec is probably sticking out, right? Sticking out in terms of hypoglycemia. The A1C reduction is neck to neck on par. However, the hypoglycemia risk seems to be significantly lower with deglutec. So if at all I want to give the best basal insulin to my patients after OAD failure, I think we are not looking beyond deglutec in such patients for a basal insulin, right? So demonstrating within the day variability, also day-to-day variability, deglutec seems to score over U300. The potency also, that is why probably when you switch from U300 to deglutec, you might also want to reduce the dosage of deglutec by about 20%. So when you switch from U300 to 200. So as I mentioned, probably the best insulin that we have, at least at this point in time, would be deglutec, right? Now, would basal insulin be suffice for all patients whom we want to initiate insulin? What are the other choices of insulin is going to be my next part of my talk. So for that, I'm going to show you another case. Here we have Mr. Amit, who's about 7 years diabetic. HbA1c is even higher, 9.2, right? So although I was mentioning about initiating insulin on time, identifying OAD failure, that's the best case scenario, right? But seldom do we initiate insulin on time, right? So And we also get patients referred from, after being denied, after denying insulin, maybe because of clinician's inertia or because of patient himself or herself hesitating insulin. So we see a lot of patients where HbA1c kind of drifts to even 10, 11, right? In those patients, would basal insulin alone be suffice? May not be. What about only premixed insulins? What about premixed insulin analogs also? Now, the disadvantage with premixed insulin analogs is that although the short-acting component may be truly an analog, the intermediate part of the insulin is not an analog, right? For convenience of understanding, suppose if a no mix is there, the aspart is short-acting, which is truly an analog, right? But the proteminated aspart, the pharmacokinetic dynamic behavior is pretty much like an NPH. So the intermediate acting is not truly an analog. And that is not going to act also for 24 hours. So you might possibly have one part of the day where the insulin has no effect at all, right? So either you have to start 2 times premixed or a basal plus, or what would be the other best choice in such patients is what I'm going to show you now. So coming to IDEGASP, this is the co-formulation. How IDEGASP is different from the other analog premixed insulins is IDEGASP is typically a co-formulation, meaning the short-acting insulin component as well as the long-acting insulin component, both are truly analogs, right? So it is not like a Novo mix or a Humalog mix. Now suppose I give IDEGASP in the morning of one day, the long-acting component has effect on next day's fasting, right? So it has a truly 24-hour cover. So that's the advantage of IDEGASP. Now the reason it is called a co-formulation is there is no overlap between the short-acting component as well as the long-acting component. So the risk of hypoglycemia is not there like the usual Novo mixes or Humalog mixes. So that's clearly an advantage of IDEGASP. So I mentioned, I think, through my, I was alluding to the safety, quality of life. So how does IDEGASP compare with insulin glargine? Now, why are we comparing glargine and IDEGASP? IDEGASP is obviously going to score over insulin glargine, right? Because it has already got a short-acting component. And we know deglutec is even better than U100. Obviously, it is going to typically win over glargine, right? It's a no-brainer. But why are we comparing this? But why we are comparing is both are once daily injectables, right? So when you're actually considering a basal insulin for a patient whose HbA1c, as I showed you in the case, is very high, you might as well consider a once daily with a short-acting component and a long-acting basal insulin analog, right? Because the chances of you achieving the desired HbA1c target is much higher with a co-formulation compared to only a basal insulin analog. So that is what is being also shown. The risk of hypoglycemia is also lower, although there is the short-acting component. You achieve a better A1C reduction still. Nevertheless, the hypoglycemia risk is actually quite lower compared to U100. Now, switching to IDEGASP, I think this is, finally depends upon the patient profile, right? So usually when you switch, it finally boils down to the patient's HbA1c, patient's blood sugar levels, patient's other combination of OADs patient is on. I think all these factors have to be considered before you actually identify the perfect dose. And most often what I do is when I switch or when I initiate, I usually ask the patient to check sugars in about 3 to 5 days. That gives you a fair bit of understanding about how much you can titrate the dose, right? I think you need at least about a couple of weeks to be closely following up with the patient to actually identify the right dose. And of course, periodic intervals later on. So how do you initiate? Again, typically you can initiate with the biggest meal of the day, but my choice is usually during the morning with breakfast. That is why I prefer to use my IDEGASP. But at sometimes patients who are having large meals, dinner time, that time would also be an ideal scenario for using IDEGASP. And then you can intensify. There are studies to show that IDEGASP given twice daily has been comparable to basal bolus, meaning basal plus 3 shots of insulin, right? Which entails 4 pricks per day. So 2 times IDEGASP has been quite comparable to 4 shots of insulin in studies with lower risk of hypoglycemia and far better convenience. So on that note, I think a lot of patients, we can reduce the injection burden starting with IDEGASP and intensifying with IDEGASP without even requiring basal bolus. The other permutation combination is when you require, perhaps if the patient's blood sugar postprandial surge is there, if you're not able to control, mitigate the postprandial surge, you can use idagasp and aspat also. That's another permutation combination that you can actually use. You can use aspat in the morning, aspat in the afternoon, and idagasp at night too. So you can play around with that. So that's the advantage, and that's the advantage of initiating idagasp in many of our patients. So yeah, there is data to show that it is safe in the elderly, safe in patients with renal impairment. Of course, deglutec is safe. It's also extensively studied. Patients with also type 1 diabetics. So with this, I would like to conclude my session. Thank you very much for a patient hearing.
Thank you, Dr. Raghavan. We will take the questions afterwards.
Sure, thank you.
So, good morning to all. The very important session is the next session again. And we have none other than Dr. Sujay Ghosh to talk about this, because he has started this role model in the state of West Bengal through the state government. And we have amongst us Dr. Selvan also sitting with me. I think you all know that he has started this model of type 1 registry in the state of Tamil Nadu.
Last month.
Coimbatore, Tamil Nadu. And Dr. Sujay will tell us about the management of type 1 diabetes public health model, which is the most important. Dr. Sujay is the Vice President, RSSDI Headquarters, RSSDI National, and he is Professor of Endocrinology. Dr. Sujay, please.
Thank you so much for that kind introduction. Big thank you to team RSSDI Tamil Nadu chapter. Every year I seem to miss the meeting due to some reason or the other. Sir has been after me and I have finally managed to come. Thank you very much. And as introduced, I'm going to talk about public health in type 1 diabetes, something that we've not discussed much in the past. So if you look at how public health has progressed in non-communicable diseases in India, we started off with the National Diabetes Control Program for adults in 1987. From there, we've come here, and now you have the NCD program for adults only. And if you go to this document and press Control F and type in type 1 diabetes, it figures twice. One, when it talks about the classification of diabetes, and at the glossary when it refers back to the classification of diabetes. So we had nothing from a national level when it comes to management of type 1 diabetes. And managing type 1 diabetes is a very difficult issue because of the economy of the country, the proportion spent on health, less than 2% of GDP, the level of awareness and education of people, which becomes managing type 1 diabetes even more difficult, lack of adequate infrastructure, and of course, challenges related to diagnosis and management of type 1 diabetes. I still believe a significant proportion of our type 1 diabetes die undiagnosed, and the ones who are diagnosed, they are probably not treated properly and then they die very quickly. The average lifespan of a type 1 diabetic individual in India is only 29 years. So you can understand 70.5 is the average lifespan of an Indian. You are losing more than 40 years of your life if you have type 1 diabetes. There are, of course, behavioral and psychological issues to be dealt with. And when you're talking about policy gaps, there is bits and pieces that some states are doing. I'm aware, Prashant, one of the type 1 diabetes patients of this state, we spoke last month about the initiatives made by Tamil Nadu government. Kerala has something called a Mithai program, which is run by the Department of Social Welfare, the Bal Madhumeya program, which is there in Chhattisgarh, and in the last 3 months, we've already launched part of my model, one in Rajasthan and one in Madhya Pradesh. So there has to be a need for a structured program wherein you are providing insulin, syringes, glucometers, strips, emergency services, and of course, facilities for diabetes education. There is no program like that. So it's not that we don't know what needs to be done. The major problem is implementation of the knowledge that we already have. So what we need is basically an implementation research. So we need a model through which a structured program you will be able to deliver medication, provide monitoring, counseling, emergency care, and an electronic registry. So we thought of that these are the key components that we would include in a public health program for management of type 1 diabetes. So that's pretty much what we are supposed to do, but what we are currently not doing. And the moment you talk about this, some of the patient groups will say, I want a 780G pump. Well, that's not possible. In a country like India, where it is estimated that you have about 229,000 children with type 1 diabetes, and probably overall close to 8 lakh people with type 1 diabetes, you can't provide that kind of facilities. So if you look at the ISPAD, it talks of various levels of care that you are providing. So we thought through a government health policy program, we would provide an intermediate care of management of type 1 diabetes. What does that mean? It will be a basal bolus regime where the basal would be glargine, and the bolus could be either human regular insulin or any of the analogs, and providing at least 3 strips a day for glucose monitoring, and providing screening for all of the complications, and minimal amount of education for non-pharmacologic management of diabetes. Can we do that through a public health model? And that model would have to be scalable, replicable, cost-effective, and in line with the National Non-Communicable Disease Program in adults. So you can't go and ask for a separate space. You can't go and ask for separate human resources. So what we thought of was we would upgrade the adult NCD clinic of each district hospital of the state. You will have the physical infrastructure there itself, the human resources there itself. How can we upgrade that to once a week type 1 diabetes clinic? So that's exactly what we did. Through the PIP program about 3 years ago, we first launched it in 5 district hospitals in Bengal, and these were dedicated type 1 diabetes clinics established in district general hospitals, OPD held once a week to cater to type 1 diabetes patients. That's the logo that has been adopted by the state as well as the central government at this point of time. So I'm going to skip through all of this because I'm going to talk about this. So we made it in a structured manner, what my PhD student calls a dummy's guide of setting up a type 1 diabetes clinic in a district hospital, because these will be people who don't even perhaps deal with even adult diabetes that well. These will be people who don't have had hardly any experience with type 1 diabetes. So these would be the steps. I'll talk about it. So the first thing that we did was a sensitization program with all of the stakeholders, where we would outline what essentially we want to do, and we would call all of the stakeholders from each of the districts in that particular meeting. The second thing that we did was we said that we would go for a hand-holding. Each district general hospital would be tagged to a department of endocrinology in the state of West Bengal, and one endocrinologist would be there in the district clinic for the next 1 to 2 years. They will not see patients, but just sit there and see what problems are these physicians, healthcare providers are facing, and they would help them in the hand-holding process of learning, because you can have a one-day workshop on type 1 diabetes, but actually can you treat or make somebody learn type 1 diabetes? The second thing was, if anything goes wrong with any of the children there is a fast-track system where a blue light ambulance would take that child from that district hospital to the tertiary care center for management if needed. Well, the first thing we did was we actually went to the clinics itself, and we identified that these are going to be the MD medicine and the MD pediatricians who will run the show in the clinic. This is the district NCD counselor, the nurse, the data entry operator, and we looked at all of the physical infrastructure that's there. We made sure that we separated out the pharmacy from the main pharmacy of the hospital. You had a mini pharmacy within the NCD clinic itself, because you have to ensure that the stocks don't run out. And in the rest of the pharmacy of the hospital, you are not providing everything like glucometer strips, lancing devices. So people will feel discriminated if in the queue you have 2 people standing, one is getting X, Y, and Z, and the other is not getting anything. And we prepared training modules and formats. So the patient ID card, diaries, logbook, SMBGs, letters to the schools, and we made a web-based application portal. So what the state of Tamil Nadu is now trying to do, we already have that in place, in the sense that through this web-based application portal, we have data of all of our type 1s and all the treatment that these patients are getting. So I know when the patient is coming back next, what was the HbA1c last time, what is the prescription. So e-prescribing, data keeping, data tracking, as well as stock keeping is done through this particular software. And we did a state level training program. There are certain components of the training program which I'm not going to talk about. And then we had an initial field visit to make sure that they had everything in place. So we've made checklists like that so that everybody knows that these are the things that we are supposed to look at and check for in terms of what we find. So there you can see within the clinic itself, you've set up a mini pharmacy of stock taking through which the dispensing happens as well. The drugs and consumables list, maintenance of supply chain, all of the stocks are there within the clinic itself. And we then again had an initial on-site training orientation program. And more importantly, we went for community mobilization. So every ASHA worker now has a tab in which for the adults there is something called a CBAC form that they fill in. We've created a CBAC form for the children as well. So every time the ASHA worker goes to a house, figures out, is there anyone with diabetes or child with diabetes, or is there anyone with these symptoms, that child gets fast-tracked to this particular clinic. And there is these doctors who have actually set up this clinic in the district, they are going down the rung to every healthcare facility to let them know that a facility like this has been started where you should be sending the patients. And these are the 4 warning signs of having diabetes. If you find someone like that, please check the glucose and diagnose diabetes. So this is an example of one of the clinics that I've talked about. And every 3 to 6 months, we are having group education sessions in terms of camps. So this is what we are supposed to be doing in each of the clinics, which you are doing in your own clinics perhaps, but it is very much structured so that nobody forgets. That software will tell you it's been 1 year you have not done the ACR. A pop-up will come up automatically. So simplifying the more complex task for the non-specialists. So this is one more of the clinics. That's the ID card that they have. These are the routine anthropometric tests, disease monitoring screening, the SMBG logbook, the letter to the schools. We've created a separate module for the school health program for the districts for management of diabetes. These are the tests that we are providing free of cost. And this dedicated HPLC machine for A1C has also been procured and been provided for each of the clinics. And this is the list of consumables that are provided to the patients every month. The trained nurse actually provides it. This is the IEC material, educational material, and the monthly follow-up that we tend to do, the referral if required, data keeping and stock maintenance. So if I very quickly show you the results at 1 year in 3 of the clinics, you will see that we've enrolled about 200 odd children in 3 district remote hospitals, wherein if you look at that majority of these children, their parents have not even completed primary education. So that's the kind of population that we are looking at. If you look at the family income of a family of say 4.5 individuals on an average, the monthly income is only 7,000 rupees. If you're looking at the socioeconomic strata, 40% of them are below poverty line. And at baseline, if you're looking at, they haven't been doing very well. At baseline, only about 58% were on basal bolus. At the end of 1 year, we were able to switch over everybody to a basal bolus regime. Their insulin injection sites were unhealthy in about 20% to start with. That has improved dramatically at the end of 1 year. And most of them have now started checking their blood sugars alone on themselves and not dependent on the parents. It's only the kids who are below 7 years of age, we ask their parents to assist the child in the testing. The fasting sugars have come down, the post meals have come down, A1C has come down by 1%. And in the 1 year follow-up period, you can see 0 ketoacidosis, 0 hospitalizations, 0 deaths. And overall hypoglycemia incidence have come down. If you're looking at the psychological well-being score of diabetes-related health, that's improved. General well-being has improved. Family functioning and social support has improved. Now, what about costs of therapy? So I told you these families on an average were earning like $7,000. And of that 50% they were spending on the health of one child per month before they were enrolled into the program. That is 3,500 was the minimum kind of cost that they were spending. At the end of the program in 1 year, that monthly cost has come down to 442 rupees. Great savings in terms of the children. So where are we going? So we initially published our data in Lancet that this should be the model of care for the nation, for management. We published our methodology paper, so anybody who wants to read and find out how to implement the same can do that. So last year's PIP, that is Program Implementation Plan, we have now got permission for expansion of the project to another 15 district general hospitals. And you can see that the new training program that we've done in those newer centers. This won the Best Practice Award for the state of West Bengal for health. And now, with the success that we've had, now JDRF, which is now renamed as Breakthrough Type 1, they are now part of my program and project. UNICEF is adopting our program in 9 states in India. WHO has tied up with us, and JDRF is working with us through the Clinton Health Access Initiative. And the central government had asked me to be part of their national committee. We had approached them that we would want a national health policy for NCDs in children, and the type 1 bit of the program has been written by me. It has been months that the document was lying. Only recently they have again revamped the entire thing, and we are hopeful that within the next month and a half to 2 months, this will be launched as a national health program. And therefore, you know, in India, health is a state subject. So unless and until there is first a national health policy, then the state can adopt that, and it will be up to the state then to be receptive enough to implement that in each of their states. So hopefully, this will improve the outcome of our children with type 1 diabetes. I shall stop there. Thank you very much.
So thank you very much, Dr. Sujay Ghosh. We will take up the questions during the discussion. It was a very useful topic you covered. And definitely during discussion, we will also touch upon the initiatives taken by the government of Tamil Nadu. Next, we invite the renowned endocrinologist, Dr. Krishna G. Seshadri, sir, to come and present to us about the circadian rhythm, its impact on the glucose metabolism. Welcome, sir.
Thank you very much for having me here. It is indeed a pleasure to be here on this time of the year and be part of TRAC. I have no conflicts with this particular talk. I have in the past talked, and most of you have been aware of how we have played with nature. So more food, more frequent food, change in quality, processed food, more light, less sleep, disturbed sleep, change in the circadian rhythm, and the other things I've talked about. My interest in the circadian rhythm is for many years. This is one of our first work that we showed that sleep disturbance increases HbA1c, right? And then we've looked at rotating night shift and risk of obesity. And this is Pan et al. In 2011 who also talked about it. But much before that, Ken Polanski actually showed that the first disturbance in diabetes is actually a lack of the rhythm of insulin secretion. Remember that the alpha and the beta cells are mirror images of each other in terms of electrical activity, and they mirror each other. And the loss of that rhythm is the first thing that happens in diabetes. So we know that at this point of time that there is a disrupted circadian rhythm in diabetes. The rest of my talk, I'm going to spend a lot more time on the beta cell and circadian rhythm, but I just want you to understand that it includes an altered light cycle, disruption in sleep-wake cycle, activity rhythms, mutations in the clock genes, change in fasting and feeding, shift work, and of course chronotype. And I've talked about it in many fora, and many of you have been there, so I'm going to sort of bring this down. Remember that there is an evidence base for this. We know that circadian rhythm has adverse metabolic health in both animals and humans. But in terms of bridging the gap, there are a whole bunch of things that are still experimental or hypothetical. So remember that when I speak about this, some of these are hypothetical and not necessarily having a very, very strong evidence base. Did our ancestors know about this? It's very interesting that the Arunaprashnam actually talks about the heat of perception as setting the clock. It's very interesting because until 2018, we had not described that the thermal sensors that we have actually set the CNS clock. We only think about light, but it's actually the heat also. Interestingly, this is Fritz of Capra who talks about the dance of Shiva as the concept of biological rhythm. He talks about it. It's a continual dance of creation, destruction, involving the whole cosmos, and the basis and existence of all phenomena. For people of you who know a little more about Nataraja, remember that the Orion constellation has been the timekeeper for us for centuries. And in fact, the image of Nataraja is based on the Orion constellation. The Arudra Nakshatra is Betelgeuse, that's right on the top, and there was a supernova in the Arudra Nakshatra constellation 1,000 years ago, which Kalki talks about in Ponniyin Selvan. Right? So humans have circadian rhythms, and that's the most obvious, light, right? But there's more than that, that we actually have other rhythms that control us. The circulunar rhythm, the most obvious is the menstrual cycle, right? But it's, for example, this ant, it's called the antlion. The size of the cavity that it digs in the sand varies depending on the circadian rhythm. Humans themselves their time to sleep is changed because of circadian rhythms. When we insulate ourselves in a room with just air conditioning, no natural light, no moonlight, it changes. There are circa-annual rhythms that, for example, there is actual. This is a mouse that undergoes hibernation. How does it know? It's a rhythm. Tropical migration is maintained by circadian rhythm. I don't want to get into it, but the cicadas have a 17-year rhythm. There are some locusts that are found based on prime numbers, the Fibonacci sequences, right? So all of these biological rhythms have a genetic origin. They're controlled by a biological clock that is located in the hypothalamus, but each cell has a clock. And this controls metabolism and is controlled by metabolism. I think those are the two parts that we want to talk about, right? And these are entrained by light, by environmental stimuli. So the German word for this is Zeitgebers, and basically these sensory perceptors set the clock. They change the way we feed, we release hormones, we do metabolism. To take this back into energy, the important thing to understand is that at the most primitive, we are hardwired for energy. Light is associated with food production, or the opposite in nocturnal animals. And when you're asleep, you regenerate. This is an inviolable law of nature. And remember, food is associated with glucose, therefore photosynthesis in plants occurs during day, and it's linked to light. When you sleep, some other fuel is available, non-glucose, and there is regeneration. Now we know that this is mediated by a clock, right? That these clocks, the internal clock is mediated by these two particular proteins, the BMAL. They cause expression of these proteins, the PER, the CRY, the ROR, the RevRB, and these go back and feed the expression of the clock chain. This is the basis of it. It's a dual cycle that occurs. And this occurs not just in the hypothalamus, it occurs in every single cell. And therefore, this controls the way we eat, the way we expend energy. It's also important that the way we eat and the way we spend energy also controls this clock. So these are what we call entrained by metabolism. So these clocks, entrained clocks in the liver, the adipose tissue, the stomach, the adrenal, and of course the intestine. Now what we know is that this clock works through a process of acetylation. It controls the clock machinery. It works in the nucleus in metabolism. It works in the cell cycle. It has epigenetic control, and it regulates sleep. I'm sorry I'm running fast because it's 15 minutes, but let's do this. So clearly, we run a circadian rhythm. At different times, the glucose metabolism is active. I'll show you data. At different times, the fat metabolism is active. At different times, even glucose-stimulated insulin secretion is active. They're all dependent on a clock. And this clock takes care of clock. And based on how it interacts, it has an impaction of gluconeogenesis, on adipocyte differentiation, on inflammation. So pretty much we are controlled by kala or time. right? And now we know that there is a differential input to the clock into metabolism, and the clock determines, besides availability of fuel, what gets active. For example, the glucose enzymes are active during the day. The fat enzymes are active during the night. You can activate them by eating, but they are not at their peak when they are not supposed to be active. And when you keep on stimulating them when they should not be active, you cause dysfunction. It's very simple. Everything has a time and a place. As people say, there is a desha, kala, and pata, right? If you do it at the time, at this place, at the opportunity, it is optimal. If you do it at some other time, it becomes suboptimal. In fact, at the level of the mitochondria, where there are two different inputs, there's a glucose-based input, there is a fatty acid-based input, right? The mitochondrial enzymes are also circadian. For example, this is the mitochondrial partitioning that occurs. In the light phase, these are the ones that are active. In the dark phase, the others are active. So clearly, what is happening is, this is hardwired into us. Light equals food equals glucose activating enzymes. Darkness equals rejuvenation, reduction in enzymatic activity, mitophagy, and the others. So this sort of tells you how this changes. The rhythmic activity is almost 62% of the mitochondrial activity. And this is what is happening. So when you're not able to switch between one enzyme to another, from a light activity to a dark activity, which occurs in diabetes, you get metabolic inflexibility. You're not able to handle diabetes, and the source of diabetes, in one of the causes of diabetes, is the lack of the ability to turn off and turn on because you have fuel available all the time. The body is confused whether it's light or dark. And of course, most of these are mediated by epigenetic changes. I'll say it. I just want to bring in something that we did several years ago. We published in 2020. So this is an experimental study that we did on animals. We took rats. Remember, rats are night feeders. And we switched them to two: regular photo period, an increase in the amount of light, and third, put them to a nurse's shift, right? Guess what happened? The metabolic parameters all became abnormal. I won't get into it. But look at what has happened to the pancreas. This is normal. On this side, you'll see that the pancreas is fairly intact. Night, day, feeding only during when it normally feeds. When you reverse the light period, daylight, and feed it at the opposite time, pancreas is expanded like an obese person's pancreatic tissue. But when you submit it to a nurse's night shift, the pancreas actually degenerates. There is enzymatic degradation of the pancreas. So clearly, the clock controls metabolic rhythms. But does it control the beta cell? And the answer seems to be yes. This is the islet cell circadian clock that is controlled by BMAL and CRY. When you change it from light to dark, can you see that the insulin secretion changes, but immediately the output also decreases, right? And in a person who is predisposed to diabetes, the shift in the clock actually causes some amount of apoptosis, right? So clearly what we now know is that there is a sleep time in the beta cell where there is cell cycle, DNA replication and repair, and then there is a metabolism time, which means the mitochondria are active when glucose is required. When it's not active, this particular protein called the UCP dumps down. It suppresses ATP, and it suppresses glucose-stimulated insulin secretion. Glucose-stimulated insulin secretion, we think, responds only to glucose, but it is clock-mediated. Only when you eat at the right time is the right amount of insulin going to be secreted. That is the key to it. Right? I won't get into fasting. I've done this many, many times. I've talked about time-restricted eating many, many times. Won't talk about it. I'm happy to take questions. I'm running out of time. But what is important is to understand that the next generation of medications are talking about clock stabilizers. Besides telling you, eat on time, don't eat at night, restrict your carbs at night, all the other things, the next generation is talking about clock stabilizers. So very interestingly, this TW68 and KL01 are the first one. They stabilize a protein called CRY. CRY is something that goes from the cytoplasm into the nucleus and suppresses BMAL. So you can actually inhibit CRY in the nucleus, just like FOXO. You can inhibit CRY in the cytoplasm. It prevents CRY from growing into the nucleus. Therefore, it overexpresses BMAL. When it does that, it causes GSIS, so which means it's a clock stabilizer. Interestingly, metformin also partly works by clock stabilization. It increases the expression of BMAL in vitro cells. And it also works on KIR 4.1. I won't get into it, but it's interesting that in a DB mouse, when you give metformin, there's an increase in expression of BMAL1. So part of the work of metformin is this. But the very interesting thing is that when you upregulate BMAL1, that is, that you increase the expression of BMAL1, beta cell function is restored in pancreatic islet cells. And one of the drugs that does this, behaves like BMAL1, is this drug called Nobiletin. Nobiletin actually restores BMAL1, restores the circadian rhythm into the pancreatic beta cells, and can restore beta cell function. So I have 1 minute left, so I want to give more time for discussion. So it's very interesting. So what have we learned? We have learned that there's a biological rhythm. We march to a biological rhythm. Metabolic disease occurs when we F-word the biological rhythm. We keep doing things, we eat at the wrong time, we work at the wrong time, we don't sleep, we are exposed to light. And in fact, I think one of the things that we should do is stop reducing the amount of light that we have at night. It needs to come down, right? Metabolic disease, when you disrupt the biologic rhythm, you get metabolic disease. But remember that metabolic disease also works by disrupting the biologic rhythm. For example, inflammation upsets the BMAL expression. When you restore biologic rhythms, you restore homeostasis. The simplest way is to adopt a good lifestyle. The complex way is to look for a drug. I just want to get back to this Nataraja thing. And again, Fritz of Kappa talks about it. In the sacred he creates and preserves, this is the Koneri Rajapuram Nataraja. We are part of this dance, the eternal rhythm, and woe to us if blinded by illusions. We detach ourselves from the dancing cosmos. If we are away from the universal harmony, our body becomes disharmonious. Thank you so much. Appreciate it.
Thank you, Dr. Krishna. Please stay here only, because now there will be a lot of questions. And you have covered this biological clock, the biological rhythm very well. One thing which I want to ask you, is there anything, in other speakers also please join here. Is there anything from the Government of India in the pipeline to decide about the working hours, to look after the biological clock?
At this point of time, everybody is talking about 70-hour weeks, sir. What is it? I've had actually, it's very interesting that I've had chats with, I keep talking about that there is an economic impact of our economic improvement, right? There's a health, and the health impact today is the economic impact of tomorrow. That means we have older people, we have to take care of people, our families are gone for a toss. Nobody wants to listen to it. I've even had chats with people sitting in the Niti Aayog, maybe you should do this.
Maybe in the times to come, when our country becomes more dependable and leader in the economics, then we may think of this.
By the time our fertility rate would have gone down, our population would have aged, and we would be looking for nannies to take care of us.
Right. Another question to Dr. Sujay. Dr. Sujay, you told about the enrollment, human resources as the MD physicians or the pediatricians. Why not the MBBS people? Because those are the people who are in most touch with the population.
Right. So I had only the option of people available in a district general hospital. So in a district general hospital, you have a NCD clinic, a non-communicable disease clinic for adults. That is run by MD medicine physicians. So all that I could do was, along with them, get pediatricians. Because some of these children would be really young and would need issues related to pediatrics help as well. So I thought that was the best mix, because me asking for new resource, whether I want another person of whatever sorts, was not an option, because whenever you're trying to scale up something at a government level, first thing government will ask is, I don't want to spend any more money, I don't want to employ anyone new, can you do this without getting more human resources into it? So that's the best bet that I
Maybe
thought.
in the times to come when we reach to the tehsil level from the district, then
Sir,
we can involve many more people.
Agreed, but right now we have nothing in terms of type 1 diabetes. India has 800 plus districts, and there are about 734 NCT clinics at the level of district hospitals already established in India. At least if we can reach that level, I would look at that as success in the phase 1.
Dr. Sujay,
Can I just add 1 second? So I actually work with the National Skills Mission, the healthcare team. I just want you to know that their priorities are how can we make sure that MBBS practitioners can write a good prescription, write a death certificate, start an IV line without problems. So there is a lot of upskilling that needs. In fact, I conducted a survey on all graduating medical students. The number of students who are confident that they can put an IV line is less than 50%. Number of students who can write a death certificate is less than 30%. The number of students who can assist in a labor is less than 40%. Number of students who can work who say that they are comfortable working in a primary health care center is 60%. Our MBBS skill sets are very poor, sir.
So, to answer a point on Dr. Sujay, before coming to sir, I have read your paper and I've also seen your West Bengal model, and I would like to share what we initiated on 14th August by launching a type 1 registry in Tamil Nadu. I would like to talk about it because we have to see how these two things are little different in their approach. So what we have done is we have gone for a model of involving all the pediatrics, general medicine and diabetology department in 38 district medical colleges, mean the district level medical college hospitals, plus we have involved 6 district headquarters hospitals. So they add up to 44. So we have made them as nodal points, 44 nodal points, and the Institute of Child Health Egmore becomes a state nodal center. And then we have given them the login in the portal to key in all the line listed patients. That is one. And we also have signed a MOU with the Tamil Nadu Type 1 Diabetes Foundation so that we can reach out the patient-centric activities in the field. That is the MOU which we signed in August. So we are going on a little different pattern from what you say. And RBSK we have involved in order that the children, either confirmed or suspected, they are channeled to the DACs for confirmation. And again, DACs have been given the login in the portal to build. So far we have about 2,500 line listed type 1 diabetes children and adolescents in our portal. That's a very beginning we have made, since I said it was launched only in August. But this is how somebody else also asked the same question, like sir was also asking, chairperson also was asking the same question. So this is how we have set our path in Tamil Nadu. And definitely it is a little different approach we have taken compared to the West Bengal model. So that's just a comment. I thought you can come back over to sir.
Actually, do you have, from your experience of working in West Bengal, do you have any prevalence of type 1 diabetics in the community?
Right. So there are, I think, about 5 publications in India with regards to type 1 diabetes prevalence and incidence studies. The challenge and the problem is most of the data that people have got is from either from pharma companies to figure out who is getting insulin, or is very skewed because most of the centers where type 1 diabetes care is provided is centered in the cities itself. Just to give you a bit of the news, I had a chat with Dr. Mohan as well. He has drafted a protocol wherein we have thought of in 5 districts in 5 different places in India, we will do a true incidence and prevalence study. We had a discussion about a month ago where we will use the capture and the recapture method to actually figure out. These districts have been identified where influx and outflux of individuals is minimal and is away from the so-called centers of excellence, so that we can actually have a true incidence and true prevalence study. So the 2 sources that people usually tend to quote is, one is the IDF data, which is an estimation, which says India has 229,000 children with type 1 diabetes. And the second is the T1D index paper that was published by JDRF. The second version of that paper is going to be published at ISPAD Lisbon on the 16th of October, which suggests that India has somewhere close to about 9 lakh type 1 diabetes. But both are very, very rough estimates. We really don't know. And like I said during my talk, I think most of our children don't get counted because they die before they get counted.
So the
One question,
Yes,
sir.
sir.
To Dr. Krishnaji, says, yes, sir, talk was really elegant, excellent. My question is, beta cell adaptive responses are observed during pregnancy. There is a change with reference to threshold for glucose-stimulated insulin secretion, GSS. Can we get similar type of change with reference to threshold for GSIS?
Yes, sir. I think so. Because what we know is that there is a set level and this set level is circadian, right? For example, the glucose response, I didn't want to go into it because it's a short talk, but the glucose response at night, the amount of glucose that is required to elicit a response in GSIS is higher at night than in the morning. That's very, very, there are some very, very elegant studies in this area.
So we are just finishing, but one question to Dr. Raghavan. Dr. Raghavan, when we talk of the IDEC ASP, most of the patient, it has been seen that with one dose, they are not getting under control, and we have to give 2 doses.
So actually, it depends again on which HbA1c level you are starting at. I think if you are able to initiate without too much of delay, I think it still works because when basal insulin itself can work, the co-formulation will actually work better than basal insulin. So, but however, in patients whose HbA1c is very, very high, then you might want to intensify to twice daily. But otherwise, once daily, I find it quite effective in many of my patients where I initiate on time without waiting too much.
Thank you very much. With that, we finished. Sir, yes, sir, last question, please.
Good morning, Dr. Krishna. It's a very nice talk as usual. Circadian rhythm and intermittent fasting, your opinion.
Okay, I thought I was going to avoid this, but if you look at it, there is a 2-bit difference. What does fasting do? Fasting actually gives a lot more time for the body to recover. That's all it does. So there's a greater amount of mitophagy. There's a shift from plenty to poverty, and therefore prolonged fasting allows the body to recover. It is a repair mechanism, correct? But people have started equating this with a circadian bit. The truth is there is really no data, although how does intermittent fasting improve glucose control? Purely by reducing the amount of food that we take. That's all it does. But respecting the time of eating, meaning aligning your food and your medication to the time when GSIS is the highest. For example, I was just talking to Arun that one of the things probably we should look at it is, if we eliminate carbs at night, will we do better? So a lot of work that needs to be done on aligning food to the right time. The current studies that are there, the TFR studies, the intermittent fasting studies that we have not looked at this in detail. They just look at random numbers, 14:8 or 16:8, these kind of numbers. But I think what we really need is a good study that looks at an alignment. For example, at 11 o'clock in the morning, if you eat, what happens? And what happens if you avoid carbs at night? Those studies need to be done, sir.
In lighter vein, I can say most of the doctors are sleeping after 12 o'clock or 1 o'clock. And one patient came and told me, sir, the doctor gave appointment early morning 3 o'clock. I was surprised. What is your suggestion or advice?
Sir, I have a lot of friends who are doctors. I don't want to talk about it.
So we thank all the 3 speakers. I think you have really provoked the thought process of everybody. And we look forward to more discussion for those who would like to ask more during the lunch hour. Yes, sir.
So, thank you very much. Myself being the organizing secretary of the upcoming RSSDI 2024 National conference at New Delhi, Yashobhumi, from 14th to 17th November this year. And I have to make two very important announcements. One for our senior colleagues, above the age of 70 years. I can see good number of people, I will not count. So anyone above the age of 70 years who wants to attend the RSSGI conference at Delhi, the organizing committee declares that they will be registered complimentary. They have to make their own travel and stay arrangements, but the registration will be complimentary, and you can directly send me your request on my WhatsApp number or on my email WhatsApp number. I will display during my deliberation post lunch, and my email is very simple: drjksharma@gmail.com. Number one. So this is for our senior colleagues. Now for our youngsters up to the age of 35 years, those who practice diabetes, those who are into the research, those who are publishing papers, those who have sent their abstracts or are sending their abstracts, they will be registered when the abstract is accepted. And good thing is that the scientific chair has been from Tamil Nadu, Dr. Vijay Vishwanathan. So please send more of abstracts. We are extending the date by 6 days up to 6th of October on special demand. And they will be registered complimentary, number one. And number two, these youngsters, those who want to come and attend, I request the Tamil Nadu RSSDI, they are very active academically, to please give them travel grant. And we will look after their stay. The number may be anything between 100 to 200. So come forward, do this. So these are the two announcements which I wanted to make. Thank you very much, sir. Thank you, sir.
Thank you for the wonderful gesture, sir. So we are winding up the present session. We request the chairpersons to hand over the mementos to the speakers. We request Dr. J.K. Sharma to hand over the memento to Dr. Arun Raghavan. We request Dr. Gerald to hand over the memento to Dr. Sujay Ghosh and Dr. Krishna Seshadri. We request Dr. G. Vijay Kumar to hand over the mementos to the chairpersons, please.